Good evening, everybody. Thank you for joining us tonight. On behalf of Ramsay Healthcare and Pain Specialists Australia, I'd like to welcome you to an information evening on chronic pain. For those of you who don't know me, which none of you will actually, my name is Lindy and I represent Ramsay Healthcare tonight, along with my colleague Sharon, just there. Ramsay Healthcare is an Australian-owned private healthcare organisation that was established in 1964 by Mr. Paul Ramsay. We're now the largest private healthcare provider in Australia and a global company. We deliver a range of acute and primary healthcare services across 11 different countries, and this makes us one of the largest and most diverse private healthcare companies in the world. Here in Victoria, we have 13 surgical hospitals, 1 mental health facility, 2 rehab hospitals, and all of our sites are highly reputable with state-of-the-art facilities. Pain Specialists Australia currently works out of 2 of our facilities, the Avenue Hospital in Windsor and Warringal Private in Heidelberg. I'm certainly very proud to work for Ramsay, with our value being people caring for people. Tonight, we're very lucky to have 2 pain specialists presenting to you. We've got Dr. Nick Christelis and Dr. Stefan O'Connell from Pain Specialists Australia. They'll be here to present and to answer your questions. Nick, I'm sure, will tell you a lot more about Pain Specialists Australia in a minute, but I'm just going to do a small bit of housekeeping. For anyone that would like to ask any questions, this is the perfect opportunity. So down the bottom, you'll have an icon with Q&A. Please feel free to type in any questions. Stefan will get to you, either just type some questions in response, or at the end, we'll answer some verbally for you. I'll also be running a couple of polls tonight. Now, it's totally anonymous, so please feel free to answer them. This will also help Nick and Stefan answer your questions and sort of tailor them to what you're after. This meeting will run for approximately 1 hour and Nick's presentation will go for approximately a half an hour. So there's lots of time for Q&A. So please start typing in and we can get to as many questions as possible. All right, so we can stay on time, without further ado, I would like to introduce you to Dr. Nick Christelis, pain specialist, who will be presenting tonight. Over to you, Nick.
Okay, first things first, hi everyone. How does the screen look okay? Good. So my name is Nick Christelis. I'm a pain specialist. I'm also an anaesthetist. There's a word in front of you on your screen, pain. It's a very small word, but as you're probably aware, it can absolutely destroy people, destroy lives, and this is partly what we're here to talk about. So firstly, I don't have any disclosures. I don't get paid by any medical companies, any medtech companies, any pharma companies. I'm standing here because I believe in what we do. Just a little bit about tonight. Lindy's gone over everything, so I'm not going to spend too much time, but please ask your questions. And if necessary, I do my very best for us to answer as many questions as possible. So it'll go for about half an hour or so. I'm going to touch on quite a few things. I'll probably talk a little quickly, but I want to have something for everyone and hopefully get to what you need. We'll start from the beginning. Is pain important? And the answer is clearly yes. The National Pain Strategy is from 2010, and it's one of the first in the world to actually talk about chronic pain. What it says is a couple of things. 1 in 5 of us are going to have some form of chronic pain, and that's pain that stays with you for a period of time. The number is 80%, and 80% of those are not going to be getting the treatment that they should be getting, and that's a huge number of people not getting the care that they need. Now, it's not officially recognized as a disease, so that's the pain. people around you are not going to be understanding of what's going on because you look okay. So it's something that you can't measure or see. So people often don't believe people with pain. And that includes healthcare providers as well as friends, families, colleagues, and other. The people that are treating you have little or no training in assessing and managing pain. And of course, if you go to a public pain clinic, you'll probably wait up to a year or longer to actually see somebody. And pain affects you physically, mentally. It causes depression, anxiety, you're not productive, relationships struggle, you're socially isolated. So there are a number of things that pain affects. And this is why I have given up my practice as an anaesthetist, trained in pain medicine, and over the last 8 or 9 years developed this clinic. And effectively, this is what we're about. We know that pain is the center of your world, so we've made it the center of our world. We absolutely do not accept that pain should define you or those around you. And we're effectively using our expertise to create sustainable change. And we want to change the way people understand, people approach pain. And that's partly what our clinic is. How do we do that? Well, we are a big multidisciplinary clinic. We have pain specialist physicians. We've got physiotherapists, occupational therapists. We've got a whole bunch of allied health team. And effectively what we do is we use interventional pain strategies covered in an allied health blanket, ultimately to treat, control pain, and get people back on track. There's no one size fits all. So that's, I think, Descartes' picture from 1664. And effectively, you hurt your foot, a line is pulled in your body, it opens the base of your brain, and the spirits and demons are released. And that was the first understanding of pain. Now, it's not like that. It actually is similar to that. There are a number of nerves that connect from wherever your body hurts to the spine, nerves to the brain, nerves to the top of the brain, and then back down again. So not many nerves. However, the reason why pain is so tricky to understand and treat is because it is complex. So that's just 1 or 2 neurons. And you can see there are receptors, chemicals, cells. There's a whole bunch of things that occur for somebody to feel pain. And what I'm talking about is nociception. And nociception is just the neuron in your body switching on and sending a signal from A to B saying, there is the pain signal. That's what it is. That's all that nociception is. And you might say, well, that sounds pretty easy to settle and it's pretty easy to treat. However, when the nociception gets to your brain, everyone has a different pain experience. And people around you have probably said that pain is in your head, and it's not in your head, it's real. They just haven't got the way of getting that message across to you. So nociception, when the signal gets to your brain, causes you to experience pain. That causes suffering and a whole bunch of knock-on effects. So that's what I'm actually talking about. So if you have a look here, you've got the nociception, and when it gets to the brain, that experience that you're having is completely different to the next person with back pain or the next person with some other pain problem. And that depends on your mood. It depends on your past experience. It depends on your beliefs. It depends on your culture. It depends on the chemicals in your body. That's why only some medicines work in some people, because we've all got different chemicals and structures. That's what we're talking about, and that's why pain can be so difficult to manage at times. That's beautiful neural networks in the brain, and you can see how it can be really difficult to understand and treat pain. Not impossible, but you've got to know what you're doing. One of the first things to understand about pain is to break down those myths, because you would have said, well, you're getting old, so you should be in pain. That's wrong. If you're in pain, tissues are damaged, your tissues are broken, and this is bad. That's generally wrong. Don't exercise because it hurts. Not good. Surgery will fix this chronic pain. Doesn't usually work that way. And this is stuck. You cannot undo this. And that's also incorrect. Pain is changeable. The nervous system changes. Same way people recover from strokes, from neurological injuries, the same thing can happen with pain, but you've got to have a plan of action. So what's the first step? The first step is to reorganize things. And the first step is to actually change your understanding, your mindset. It's about accepting things and not accepting pain. Not accepting suffering. Possibly accepting that you are where you are, but there are things that can get you through this. And this is about just good general health. Being proactive, prioritizing yourself and not the people around you, not work, not friends, not family, but you, which is really hard to do. And of course, you want to build your team as well, which we're talking about. So how do we control pain? Because we've got to change things. But before we change things, we should work on ways of controlling pain. Medications can sometimes be helpful. We'll touch on that in a second. Sometimes we can do a nerve block or burn a nerve or use a pacemaker called spinal cord stimulator to help, or even a surgery to help pain. So there's a whole bunch of tools that we have at our disposal. And this is what pain care could look like. You step up a ladder. You start off with some very basic lifestyle changes, which we all get stuck if you've got chronic pain. And it's about undoing a few of those things first. So small little changes, but you need somebody to guide you. And then from the medical perspective, you've got nerve blocks, radio frequencies, which I'll come to, and even the more advanced pain management strategies that we have. So we've got these advanced therapies that we generally step up to if needed. But the foundation is physical rehab, mental rehab, functional rehab, so retraining your body again. And that takes a team to get things started. And of course, one of the most important things is to educate and empower people. So actually not to help you find your mojo again and really find that drive to succeed in your pain care. One of the chronic pains we're talking about is neuropathic pain. So that's burning, pins and needles, electric shocks, numbness. So a lot of people come to us with a numb part of their body that hurts. Well, that's bizarre, but that's exactly what happens in some circumstances. So the nerves malfunction, they don't do the right thing, they do the wrong thing and send you pain signals. Most GPs or other specialists might try you on some nerve medications, and everyone's heard of Lyrica. Us as pain specialists don't generally use Lyrica because it's full of side effects. It can cause weight gain, it can slow your thoughts down and really give you some other troubles as well. So there are, Lyrica is one, amitriptyline is one, but there are many other medications that can be considered for neuropathic pain. Now, medications don't work in everyone, but if you use the right medication combined with reducing the wrong medication, combined with a bit of physical therapy, maybe combined with a nerve block or something, then you're starting to see some change. So it's a package, it's a combination of care. Just one slide on opioids, because a lot of people will be taking opioids. GPs are being educated on the risks of opioids because they're the main prescribers. There are far more harm than benefit, generally speaking, when you take an opioid. It might work for a short time, but then the dosing stops working. The dosing needs to be made stronger. It works for a short time again, and before you know it, you're on this upward trajectory. Here are some of the side effects of opioids, and there are many. I'm just going to touch on a couple of them, but it slows things down, so you get drowsy, you get cognitive slowing. Sleep is bad. It can really interfere with sleep. It can cause sleep apnea. It can actually make pain worse in some circumstances. And we found that if we reduce opioids, we can actually improve pain control. But it changes your immune status. It changes hormones. It changes libido. It puts you at risk of fractures, and it can affect your bowel from top to tail. So opioids on the whole are dangerous. Cannabinoids, everyone wants to ask about cannabinoids. So here is a slide on cannabinoids. Effectively, the evidence is not there to support its use currently. There have been some big studies looking at this for pain. Persistent pain, and there are so many unanswered questions. What compound do you use? Who do you give it to? How much do you give it? For how long do you give it? What's the combination of these various cannabis compounds that you should be giving to each and every person? No one knows the answer to this. A lot of people are trialing it. There are a few things I wanted you to make you aware of. The NNT, which means the number needed to treat, is 24. So I need to give it to 24 people before it helps one. The number needed to harm is 6. So I need to give it to 6 people before one of them gets a side effect. And side effects can include dizziness, tiredness, nausea, and vomiting. And one of the main ones is it can switch on mental health problems, mainly psychosis. So that's a very important and very risky side effect. It doesn't work very well. The top line says compared to placebo, it works about the same as placebo, and it doesn't drop pain very much. So cannabinoids are not there yet. Now, I'm not saying we don't use it, but you've got to be very careful about it. Nerve blocks and radiofrequencies. Well, I'm an anaesthetist, so I love jabbing people with needles to help them diagnose and help them treat pain. But if you understand where the nerves are, there are many causes of back pain. And I see a lot of people out there have back and leg pain. It might be your facet joints, which I'll come to. It might be the cluneal nerve. And as you can see here on this picture, if we know where the nerves lie, we can put some local anesthetic on these nerves. And you can see this nerve here, the cluneal nerve, can sometimes cause buttock pain. And it gets caught on the iliac bone. So if you have an understanding of various pain causes, you can focus treatment on that. And back pain is one of the commonest pains we treat, of course. Now, facet joints can cause back pain, and as you can see on this diagram here, the facet joint has a couple of little nerves. So if I block that nerve, and you can see the picture on the right-hand side with the needles, and you can see that little dark, what we call contrast outlining the nerve. If I block the nerve and your pain goes away, well, then I can burn the nerve with a tiny little needle that we do under some mild sedation as an outpatient-based procedure, which can provide you with long-standing pain control, anything from 6 months to a couple of years. And the best result that I've had with a lumbar radiofrequency is 5 years. But those are the people that start exercising, make those lifestyle changes, take responsibility for things, and really kind of use the team around you to foster change. So that's what we do for some arthritic lower back or any spinal joints, facet joint radiofrequency. Now, we're getting really good at what we do in terms of pain specialty as a whole, and the same thing applies to hips, knees, and shoulders that are arthritic. And we know that a lot of patients have some minor injections done by GPs and surgeons. If that doesn't work, they have an arthroscopy and then a joint replacement. Now, I'm not saying that's not needed in some, but there is a step in between called radiofrequency ablation of the nerves of that joint. And if we know where the nerves lie, we can block the nerves, and we can do a radiofrequency of these nerves to provide intermittent pain control. So anything from 6 months to a year. And if somebody doesn't want a joint replacement, we can certainly push the pain control down by a couple of years. And we can do this once or twice a year if needed, just to keep things steady. What about neuromodulation? Who's heard of neuromodulation? Normally people put their hands up or not, but effectively this is where medicine is going. We are moving away from chemicals into biotechnicals. So we're using electrical stimulation to treat disease. The cochlear implant is one to help profound deafness. Deep brain stimulators are used for Parkinson's, shakes, and tremors. They're doing some really fantastic work on deep brain stimulation for epilepsy, Tourette's, depression, obsessive compulsive disorders. So moving away from chemicals to technicals to manage disease. Now we can do the same thing for pain, and spinal cord stimulation, which is what I'm talking about, has been around for 50 years. This is not new technology. And it can be profound in terms of pain control. This is for neuropathic pain that doesn't respond to usual treatments. There are many ways that we can apply a pacemaker to somebody to help pace pain, slow down pain, the same way that a cardiac pacemaker paces and slows down the heart. These devices can help certain types of pain. And there are many devices out there, mainly for neuropathic pain, which is severe nerve pain. I'll point you to the bottom right. There's a new device out there that's now being considered for back pain that is not neuropathic. And this is called a multifidus muscle nerve stimulator, which basically helps your muscles to rehabilitate, to get stronger. And this is an implantable device. Now, this is new to Australia, so we're starting to understand how this therapy may be beneficial to some of our patients. That's with back pain that doesn't respond to usual therapy. Nerve stimulation can be considered for people that have had any form of surgery where they're left with severe neuropathic pain, nerve pain, normally of the spine, spinal fusions, laminectomies, that kind of thing. Complex regional pain syndrome can be treated with spinal cord stimulation. That's of the hands and feet and other parts of the body. And any form of neuropathic pain, whether that be on your spine, sometimes following rib fractures and chest pain, post-herpetic neuralgia, which is shingles pain, and there are many other treatments or the many other pain conditions that may be appropriate for this therapy. And as you can see here, these little electrical wires can be applied to any part of the nervous system if you know what you're treating and you know how to use this therapy to actually pace down and slow down the nervous system. And this can be life-saving for some. Now, that might sound a bit invasive for a lot of people, but these are people that are suffering immensely with pain. And the nice thing about this is we can try it out first. So we don't put anything in the body. We strap the wires to the outside of the body with a battery on the outside of the body for anything from a week or two to see what happens to the pain. You get a remote control and we kind of program it for the pain and to see if it actually helps the pain. If your pain drops by more than 50 or 60%, then we're talking about therapy that might be beneficial. And as you can see, lots of studies out there, and they show that the pain can be certainly treated for 2 years or more. And I've had people that have had them in for many years and get sustained benefits. So pain scores of 8s down to 2s roughly on the whole. Now, with anything that is a medical device in the body, there are risks, of course. The risks are generally small. It's a minimally invasive procedure. It's reversible. So I took one out recently because her pain had been treated and stopped, so she didn't require the treatment. But there's a risk of infection. Sometimes the leads can move, and there are some other risks as well. So it's something we don't take very lightly. But again, if it's the right pain for the right patient, it can be incredibly helpful. So we're managing the pain with all these ways, with medications, injections, nerve stimulators. Well, the job is not done. The next steps, because there's a next steps, we've got to focus on relaxing. We've got to focus on turning off the tension. We've got to focus on relaxing that anxiety that pain causes. And a lot of people out there were going to have that. And there are ways that we can do this as well. Sometimes it's simple as breathing exercises. Sometimes it's motivation. Sometimes it's working with our OT or other allied health professionals. Something that you might do straight away is have a mindful snack. Stop. Being mindful is just being present in the moment. So not thinking too hard about things, just being aware of what's happening. So stop, notice what's going on. Accept what's going on. Just be aware of it. Say, yep, I've got these anxiety thoughts. I'm really worried about something. And just accept it. Don't be cross about it. Be curious about it. So kind of explore that feeling. And of course, you've got to be kind to yourself. So really look after yourself. So this is where the allied health team comes into it. And this is how we can help people to make that change once we've got some good going pain control, because it goes hand in hand. Motivation we've mentioned, so this is about finding that mojo, and sometimes it's really hard to do. Sometimes you've got to laugh, sometimes you've got to get some peer pressure, sometimes you've got to give yourself those little naughty rewards, but this is a hard grind at times, so pain management can be a grind. But if you've got the right team around you, it's doable. Nourishment is very important, so all the usual things, but I'll direct you to something called PEA, which is a healthy supplement. It's the same in terms of glucosamine helping your joints, or PEA can sometimes help pain and nerve pain, and it's very safe. It's got no side effects. Turmeric can be used, fish oils can be used, so there's a number of things, and we have a dietitian in the team that can really help people to become a little healthier, which has impact on your pain. Diet can cause inflammation. Inflammation makes pain worse. That's a fact. It's just a matter of how we go about it for each individual. This is a big one. This is one that a lot of patients with pain find really difficult, and that's accepting it. And not accepting suffering. This is accepting where you are, and that there's a path through this. And it's sometimes really hard to do. And the other is, a lot of patients that we see here are angry with people around them, are angry with the cause of pain, work, the car accident, that time when I tripped over and hurt myself. But there's no point in blaming others or even blaming yourself. And once those things start happening, change will occur. I say this to a lot of people, so if people are out there and they may have heard this before, nothing happens until you move your body. Movement is life, and this is one of the most important things in terms of people living with pain. We have got to work out a way of setting some clever goals, some small goals. We've got to get you pacing your body again. So taking those small steps, not big steps, making little habit changes. But ultimately, we've got to get you moving again. And if we can get your pain controlled, then we can put on a plan to get you moving again. Reactivate that body again. It's an absolute must. Rest is very important, and we're all really bad at resting nowadays because we've got these little things that we carry around with us, and there are things that we can do to start resting again, because if you're resting, you're getting better. And opioids destroy sleep cycles, and we found that once we get people down or off opioids, sleep improves. And there are many simple things that we can do to improve sleep. So I'm just going to go through them because it's quite important. Quiet, dark room, no TVs, no screens, well ventilated. Don't have big meals before you eat. No smoking, no alcohol, no stimulants, no caffeine, no energy drinks. And you'll be amazed at how people forget these little things, and it's all these little things that add up, and that's why pain change can take time. The right bed, good ventilation, as I've said. Go to bed at the same time and get up at the same time, whether you're awake or not. And this is about changing those sleep habits, not going to bed at 10 o'clock, watching TV until 6 o'clock. Sleeping until midday. You're not going to change things unless you change things. And of course, all these appliances, screens, games, just you got to stop that. Small steps. I've started doing that. I've started leaving my phone outside the room, and I think I'm sleeping better for it. Taking me a long time to do that though. A couple of other things that sometimes a good pain team can help you with is to rekindle those relationships, and sometimes you've got to focus on that because pain not only destroys people and their lives, but it affects the lives of people all around you. So that's a very important factor. And I'm sorry to say, once you've done all that, which is a big slog at times, but it's doable and we can get there. Once you've done all that, you've got to stop, you've got to do it again. And pain changes. So we treat one pain, another pain is underneath that and surfaces, so we've got to manage that. So there are a number of things we can do to help pain. So I've given you a bit of a whistle-stop tour of pain care and approaches to pain management. On our website, Pain Specialist Australia, there are a number of ebooks you can go and download. You just go to the bottom of any of the web pages and you can click on them and download them, and feel free to read them. Hopefully they'll give you some tips and insights. This is the call to action. If you feel like you need help, there are a couple of things you can do. One is go to our website and use the Contact Us bar, and you can fill out a little form, and there's a whole bunch of contact information, and we'll hopefully get back to you as soon as possible. If you feel like you do need a pain specialist or a second opinion, and you're ready for that, all we need is a GP referral or a specialist referral, and you just fax that to that, email that to us, or get that to us any way you need to. And again, the details are on the website. We're on all the social media platforms as well. So if you want to catch up and keep up to date, please feel free to follow us. If you have the inclination, please hop onto Facebook or Google and drop a review as well. I've tried to keep it short and sweet. That's just under 30 minutes. I'm going to stop the presentation. I'll leave that up for a couple of minutes, and then hopefully we can take some questions and answers, and I can see there's quite a few there already.
It's been great. Stefan has certainly been answering a lot of questions for everybody. Hopefully you've all had a chance to do the polls, and it's interesting, Nick, most of the pain of the people in the house at the moment are back, legs and neck, and with the majority of people, that's 57%, having over 5 years of pain.
Yeah. So that's chronic, long-standing. Your pain has changed you. Your pain has changed your body. You're stiff. You're weak. You're not moving very well, and you're in that protection mode. And it's really hard to undo. But back pain is not back pain, and I've said this a lot to many people. There are many causes of back pain, and that's why you need a good interventional pain specialist to make an assessment. Is it your facet joints? Is it your sacroiliac joint? Is it the cluneal nerve? So these are the areas that can hurt. Is it the muscles? Is it little bursa that can be swollen and inflamed? Is it disc problems that can cause a certain type of pain? Obviously, we all know about discs touching nerves, and that can cause pain down into the buttock and legs. Sometimes it's as simple as a tendinopathy, which is a sore hip muscle that needs to be assessed and managed. And I didn't mention, we can do PRP injections into little tendons and muscles, which can help regenerate and help muscle growth and heal. So it's about making a good assessment, but I will not accept the fact that you might have had pain for 2, 3, or 5 years and nothing can be done about it. And that's partly why we are where we are, and partly why we do what we do, because things can be done.
That's great. Look, we do have a couple of people with their hands up, but perhaps if those people could just type into the Q&A, that would be better. Are you happy with that, Nick? Because sometimes it's difficult.
Q&A, yeah. I'm happy for people to talk, whatever works best.
Okay. Well, we do have somebody with their hand up. Let me just have a quick look. Was it Maria? If Maria is unable to unmute herself and talk, we'd be happy for that to happen. I'm allowing you to talk now, Maria. You'll have to unmute yourself, Maria. There's an icon on the bottom of your left-hand bottom of your screen, Maria. If you can unmute yourself, we might be able to hear your question. I feel like I'm on the radio. We might have to let you go. I'm sorry.
That's okay. She can come back.
Yeah, she can come back.
Anything you've picked up, Stefan, that you want to elaborate on or answer?
Yeah, well, there's lots of questions. There's been questions about ketamine infusions.
Yep.
So someone asked me how it works. So I was describing some of the pharmacological action. So ketamine works mostly at this receptor in the spinal cord called the NMDA receptor. It blocks this during the infusion. But then there's a question about administration of this for ongoing pain relief. Ketamine is quite a unique drug. We admit patients for generally 1-week infusions, but the pain relief lasts beyond that. It is a bit variable, but certainly it's useful if sensitization is the major part of the picture, and it can often give ongoing pain relief for weeks or months.
Correct. It can be useful. I generally use it in a crisis situation, or when the pain is really kind of getting out of control and almost explosive in nature. It generally just works for the nerve pain, the neuropathic pain, sometimes the widespread pain, the CRPS, complex regional pain syndrome. It's quite nice to have a bit of a break from life and the world. And we give it in very small doses, which means you don't really feel anything. Sometimes you can get a bit nauseated when it starts. Sometimes your blood pressure can go up. So we have a few things just to keep everything nice and steady. And as Stefan said, if it works, it can work anything from a month to 4 or 5 months, and a 6-month result is pretty good. And that can be something that can be used if and when the pain gets a little out of control. So I've got some people where I see them once a year, sometimes even twice a year, for a ketamine infusion, whereas nothing else has seemed to be helpful. And this is something that just keeps things down, keeps the opioids off, keeps people at work, and keeps people functioning as well. So it's pretty safe on the whole.
There's been a lot of questions about cannabis,
Yes.
CBD, THC. So in particular, who does it work for?
That's the thing we don't know. There is a big political, cultural shift in terms of getting cannabis out there. But I saw a lady a couple of weeks ago who said, she pulled out this little syringe and said, can you prescribe this for me? I said, well, what is it? It's got no label. Where did you get it from? I got it from Queensland. I called somebody on the phone. I spoke to them for 5 minutes and they posted it out to me. So in that respect, that's generally not safe. We don't know where it's coming from. We don't know who's making it, what's in it, what the combination of CBD and THC is. We think it might be helpful for epilepsy, for kids with severe epilepsy, for multiple sclerosis and other severe neurological disorders. But the current studies, the research out there doesn't show that it works for chronic pain as a whole, chronic pain. It may work for some types of neuropathic pain, but there are so many chemical combinations out there. I don't know who to give it to, how much to give it, for how long. But on the whole, we do prescribe it, or I certainly do. I know Stefan does as well. If we think there's a bit of a plan, it can be expensive because it's not supported by the government yet. If you're on the THC part of it, you cannot legally drive. And we don't know how to measure the effects of it as well. And of course, it can affect your mental health. So it can trigger psychosis and other severe mental health problems. So we just don't know yet. And if you're going to get it, please make sure you get it from somewhere reputable. If you have questions, then reach out to us and ask us some questions. But make sure you've got somebody on your court helping you with it.
There's an interesting question here, Nick, and I know this is something that you might have some knowledge of, but examples of dietary habits that can cause inflammation.
Oh, yeah. So think about this. People are having surgeries and having these big treatments to treat medical disease, including pain, where we're forgetting about the simple stuff, the prevention, the lifestyle changes. I do my very best to exercise because I know that exercise is very helpful. I'm trying to look after mental health, and through COVID, it's been really hard for all of us, and everyone's anxiety levels are up a notch or two. But broadly speaking, with a brush in America, everyone's overweight. And studies have shown that levels of inflammation in people that are overweight and have the wrong diet, levels of inflammation are up. Just marginally, but they're up. And so if we change diet, we can improve levels of inflammation, which may have a benefit on pain. So I've got a lot of people where I had one woman who had trigeminal neuralgia. She's waiting for surgery, and she got a chest infection, and that inflammation from the chest infection triggered a pain. She ended up in hospital for 2 weeks. So when you become inflamed in another part of your body, your pain is going to get worse. So what can we do about it? Well, it's about living healthy. So fresh water, Alcohol is pro-inflammatory, unfortunately. So you might want to just start by maybe having a drink here and there. And you'll probably notice the difference almost immediately. Anti-inflammatory diet. So this is high-dose fish oils, green tea. It's all the non-processed goods. So it's also just about cutting out all the donuts and the processed cakes, those cakes that sit on your kind of table for 6 months and nothing happens to them, and the McDonald's and all these kind of non-healthy foods. So it's basically just eating healthy. But type in anti-inflammatory diets in most web browsers and you'll get a heap of information on that. But these are the simple things that we can do today, right now, to limit inflammation, which will have a benefit on your pain.
There's another good question here from a patient with fibromyalgia, but with other underlying mechanical problems. So what can she do to help manage that?
So where is the mechanical problems? Do we know?
It's not specified, but I know myself, I've often seen patients with a diagnosis of fibromyalgia, and they might have back pain due to facet joint arthritis or knee pain from knee arthritis. And these are separate pathologies that need separate treatment. Yeah,
correct. And the difficulty with fibromyalgia is quite hard to unpick what's going on underneath the pain. And of course, we're interventionists, so we like to block a nerve, do a few things to work it out. But if you've got fibromyalgia, sometimes putting a needle through your skin can actually flare up that nerve pain. But it's not to say that it can't be done. You just got to be clever about it and be aware that that can happen. It depends on where the pain is. If it's just a joint, so I've got some people with fibromyalgia and a bad knee, where we just do a knee joint radio frequency, just kind of ablating the nerves to help with knee pain, which is separate to the fibromyalgia. So the bottom line is you probably need somebody to really listen to you, assess your pain, and assess the pain that you're talking about underneath or on top of the fibromyalgia. There was somebody about femoral nerve pain from numerous pelvic fractures. Tried gabapentin, PLEA, clonidine, finally ketamine. Just felt out of it, and constant haze, forgetful. I'm an advocate for ketamine. Okay, there you go. You got somebody that's an advocate. So that's not actually a question in there. But it certainly sounds like you're suffering from neuropathic pain. So if nerve blocks radio frequencies are not helpful, or these therapies are not helpful, or giving you lots of side effects, even nerve stimulation can be considered as a potential treatment tool.
Just having a look at the polls again, Nick. About 33% of the people on the line tonight don't have a pain specialist, so they can definitely contact you or contact one of us, and we will put you in contact with Nick and the gang there to help you out. And interestingly, the first point of call when they have a flare-up of pain, they head to the GP.
Yep, GPs treat the most pain. Specialists see a very small percentage, maybe 2 to 5% of, because there are so many people out there. Jeanette asked a question about compression fracture of T8 causing pain. So when the vertebra compress down, the joints on the back of the vertebra compress down as well. So there are, depending on how old the compression fracture is, sometimes a treatment of the facet joints above and below the area of that pain can help with the pain, because it stretches the joints at the back of your spine. So that can sometimes be a potential treatment as well. So facet joint radio frequency can be considered.
Arachnoiditis pain, what can be done for that?
Do you have any thoughts on that, Stefan?
Yeah, well, this is a type of nerve pain where there's inflammation and clumping of the nerve roots within the spinal canal. Generally, it's caused as it's an inflammatory process following surgery on the spine. It's a rare complication, but unfortunately, it happens to some. First and foremost, getting a good diagnosis based on the history, the physical exam, the imaging. Treatment involves the correct nerve pain medications that are effective and with a low incidence of side effects. So this often takes some trial and error. Very often pain from arachnoiditis can be somewhat refractory, and in that instance, spinal cord stimulation can be very good treatment.
And remember, pain changes over time as well. So it might be the arachnoiditis, it might be something else that's happening as well, because arachnoiditis is normally there for a long time. But it's the whole package of care. It's the ketamines, it's the anti-inflammatory diets, it's the PEAs, and finding out what works best and kind of sticking with that.
If ketamine didn't work for more than a week the first time, could it work the second time better?
The short answer is unlikely. What are your thoughts on that, Stefan?
Yeah, I agree. I think with ketamine, you're either a responder or you're not. So I think now you could argue we could try it at a higher dose, but I think it should give some response at any dose if it's going to work.
Yes, that's right. Sometimes lignocaine infusions can be done. I know Stefan does lignocaine infusions, and some of our other pain specialists here do that as well. So it's a different type of medication. It's actually a local anesthetic that can block nerves and sometimes reset things as well. So that is an answer. What else have we got? Carol's asked if it's safe to take gabapentin long term. And the answer is it's probably the safest out of all of the medications, providing it's not doing you any harm, like weight gain or cognitive slowing down, so it slows down your brains, because really it's used to treat nerve pain, hypersensitive nerves. So what it's trying to do is damp down nerves, and it damps down the pain nerves, but it also damps down your brain and the nerves in your brain. So that's what happens. But it's certainly far safer than opioids, and it's far safer than a lot of other medications. So I would say reassess things once a year or once every 6 months. Say, is this medication helpful? Do I need it? Maybe I should come down and see what happens to my pain. If your pain spikes, then it's needed, and you go back on it for another 6 months. But you should always be looking for other ways of managing pain.
There's a patient here that has trochanteric bursitis plus a torn glute muscle. Yep. Analogous blood injections haven't helped. Pain is now going down to the foot. Trying exercise with a physio. Can exercise alone help?
I think eventually exercise alone can help, but it's a long slog. It's quite hard work. And it sounds like autologous blood, meaning a PRP injection. Sometimes you need to do a few PRP injections. It doesn't always work for bursitis, and if a tendon is torn, it doesn't actually heal the tendon. But because you're getting pain referred down your leg, it might be something more than just a local inflammatory process around the tendon. You might have some nerves involved as well, and that's why you're getting this referred pain. Normally, when you leave pain for long enough, even though it might start with an inflammatory type of pain, that pain can become nerve pain. So for example, people with osteoarthritis of the knee, we know that about 10% of people with knee osteoarthritis actually have neuropathic pain around the knee. So they've got nerve pain around the knee. And that's why sometimes some of the usual treatments don't work. You might have some neuropathic pain underneath or around that tendon pain. And that's why things are not working.
Autologous blood injections, are they helpful, Nick?
I think that's just where they take your blood, don't do anything to it, and inject it straight back into an area. What we do is PRP injections, where we take some of your blood, we spin it down and separate the yellow stuff from the red stuff, and it's the yellow stuff, the platelet-rich plasma, that is full of nutrients and pro-healing substances, and we put it directly into the area that's sore, particularly tendons or muscles, and sometimes joints as well. So we definitely use PRP injections as part of our treatment plan for the right type of pain. It's what a lot of the sportsmen use, but of course it can be helpful for some types of chronic pain conditions as well.
Yeah, injecting blood, it's sometimes done, but it's when people don't have the right equipment. I don't think there's much evidence supporting its use. All the evidence is for PRP.
Correct. So you might just need a good old-fashioned PRP injection as opposed to autologous blood injection. There's a question about neuromodulation for migraine, and the answer is yes, without knowing the whole situation. We use pulsed radio frequency to the suboccipital space. So we do some simple injections around the base of the neck, because normally migraines can be triggered by very tight areas and muscles at the base of the head. But also placing some of the nerve stimulator leads across the occipital nerves can actually benefit people with chronic migraine. I think you've got 1 or 2 patients with occipital neuralgia and migraines that you've used nerve stimulation for, Stefan?
Yeah, I've 3 patients, and they're all doing pretty well. It's
excellent.
Yeah. Well, they've been more occipital neuralgia, which has strong evidence.
Yeah.
Chronic migraine, not quite as useful, but there is evidence supporting its use. I think it's something one would consider when the simple treatments have failed and a patient is really struggling.
Yeah. And of course, the nice thing about it is you can try it out first. So it's not like we're going to stick anything into your body. We put the leads on the outside and a little bit of the lead just underneath the skin where we think it is needed. And we try that out for 5 days, 6 days, up to a week or 2, and see what happens to the pain.
There's a patient asking about gabapentin causing memory impairment. Well, gabapentin, it's one of our best antineuropathic pain drugs. It does have a better side effect profile to a lot of the other nerve pain medications, but still for some it does cause memory impairment. So perhaps one option might be to try to reduce the dose, maybe add something else in. Sometimes combination therapy of nerve pain medications can give a better result, but with less side effects. So for example, by reducing the gabapentin and maybe adding an antidepressant such as duloxetine or amitriptyline, you might be able to get a better result.
CRPS of the foot, that's from Rebecca. Depending on how long you have had CRPS, Rebecca, again, it's the same thing. We've got to focus on fitness, function, fear, lack of movement, those simple things, and then we can trial the medications. But there's a little bit of evidence for ketamine infusions, and there's certainly some evidence for nerve stimulators to be used early-ish in the phase of CRPS. But I've successfully used it in people with CRPS that have had CRPS for 5 to 7 years. So it is still a consideration. So yes, there are things that can be done.
What is the best evidence-based treatment for fibromyalgia?
Fibromyalgia is something that in days gone by, people didn't really understand. It used to be called fibrositis. It just means I don't know what's going on. But nowadays we know that it's a real medical condition. It's widespread pain, and we prefer the term widespread sensitization. So everything is switched on, all your nerves are hypersensitive. It has profound effects on mood, function, and it also is profoundly correlated with fatigue as well. The only way to manage this is with a team that understands it. You've got to get off opioids and onto the right medications, but this is about small and steady steps. In terms of medical therapies, there's an early case series where in some people nerve stimulation, so spinal cord stimulation, can be used for widespread pain. I've used it in 3 people. Now, this is something that's not highly supported by research, but again, you've got to take each case on a case-by-case basis. I've got one person that's doing really well. He's weaning himself off all his medications and he's got widespread pain. And I've got two people that are doing so-so. But it's a consideration, but it's a constant hard work problem. I don't know if you've got anything else to add on that, Stefan.
No, not really. I think you gave a very concise answer there. Can CRPS be cured or just brought under control?
Good question. Yes, if we see CRPS early, we can cure it. Now, early means days and months, days, weeks and months. We work with a number of surgeons who can diagnose it quickly because it normally follows a surgery or a broken bone or an injury. But like most pain, if you've had the CRPS for years, this is about controlling it being a chronic illness. Now, having said that, the first neurostimulator device I ever used, I put into a lady with CRPS of the hand. And about 4 months ago, I removed the device because her pain had gone and she did not need it anymore. She still had quite a clawed hand, but it functioned. The first year of the treatment, she got off all her opioids. The second year, she started thinking about driving again. The third year, she started driving, went back to work the fourth year, and the fifth year, she didn't need it anymore, so we've taken it out. So this is partly why we're doing what we're doing. We don't believe that just because you've had pain for years and everyone's put you in the bin because they don't think there's anything that can be done, we completely disagree with that. We would assess the situation and have an open and honest think about possibilities.
Yeah, that's well, that's it. Yeah, early referral, and we can cure patients with very simple measures. But then when it's quite chronic, we might need the more high-tech solutions.
Yeah.
There's a patient here. Since working from home, this patient has been getting pain at the back of the head on the right side and very sore. So what sort of assessment and treatment options would this patient have?
So this is pain on the back of the head. We've got to ask, is it a musculoskeletal pain? So is it a joint problem? So it might be stiff turning your head, or it might be really sore when you tilt your head backwards and close the joints of your spine. So is it a referred pain where you're getting cervicogenic headaches? And that's treated with radiofrequency treatment, sometimes nerve blocks as well. If it's a spinal cord problem, sometimes an epidural injection can be helpful. But if it's muscles trapped in this area, now sometimes when people pull their neck forward, they kind of pull nerves in muscles, and you can get what we call great occipital nerve entrapment. So sometimes a nerve block or radiofrequency can be considered as well. And there are lots of nerves around that area. I had somebody with severe ear pain because of a firecracker going off, and we've treated her successfully with Botox injections onto the stellate ganglion. So sometimes we've got to think outside the box. But there are many potential causes for pain at the back of the head, and you just need somebody that knows what they're doing to listen to you, examine you, and come up with a plan of action.
There's a query here about PRP injections. So Eve Gilbert is interested in exploring PRP, but her GP is a little bit skeptical and isn't fully convinced by the evidence. Now, the particular issue here is a bulging disc with a minor annular tear with sciatica. Now, PRP as a treatment, it's been around maybe a decade or two now, and early studies weren't that supportive, but as the treatment has refined and as the studies have improved, we have some very good randomized control trials. Specifically, there's very good evidence for tennis elbow, for early knee osteoarthritis, and for gluteal tendinopathy. Studies for other conditions aren't quite as convincing, and I think this is sort of an area that's evolving. But I know, Nick, you have an interest in PRP for discogenic pain.
Yeah, so if people have got disc pain, so this is not facet pain, this is not a disc prolapse. This is inflammation around the disc, which is really hard to treat. And sometimes the only treatment is for a surgeon to take out the disc and do a spinal fusion. But we can put some needles into the disc and lightly heat up the disc. Now, the disc is like a tire that separates one vertebral body from the other. And the outer part of the disc has got nerves, and that's why it can sometimes be painful if it gets inflamed. And putting a needle into a disc, doing some pulsed radio frequency, and putting a few drops of PRP into that disc can sometimes be helpful. And again, studies are not strong, but if you select people correctly and you talk about potential options, I probably have a bit of PRP put into my disc before a surgeon took it out and put a couple of screws in the area. So it's a balance between pros and cons, really. And there's always an option of doing nothing, but most people would want to explore something relatively low risk. But I think PRP, and that's the earliest form of regenerative medicine. So we're not talking about stem cell therapy. Stem cell therapy is definitely not there yet, but PRP is very safe. It's very minimally invasive, and for the right condition, like Stefan said, it can be helpful.
Maria Canalos finds it difficult to explain her pain to medical practitioners.
Yeah.
And this makes it difficult to get help.
And part of the national pain strategy stated that a lot of people don't understand pain. And we get our patients to fill out an 8-page questionnaire, so you can do it in your own time at home before you've seen us, and really try and put down what you feel is your pain or how it affects you. That's what we do. We work out ways of assessing pain.
Movement disorders associated with complex regional pain syndrome. Any suggestions? And the patient
so if intrathecal therapy can be considered, intrathecal baclofen can be considered, spinal cord stimulation can sometimes be considered, but sometimes you just need the right kind of chemical as well. It's a really hard one. You need a good rehab. You need a good rehab team around you.
I'm getting some questions around whether or not this video will be available for people that that might have some pain, or if you've missed something and you want to listen to it again. We will absolutely make it available on our websites. We just need to edit it all and upload it. So for the people who have registered tonight, we will let you know via email in a follow-up.
Good. Do you want to take a few more questions, Lindy, or are we going to wrap it up? Because I know there's lots of questions.
There are lots of questions. It's really up to you. Did you want to go for a little bit longer?
Yeah, I mean, let's answer a few more questions. I've got a few more minutes.
I'm happy with that. We've had not too many people drop out, so why not?
What else do you see, Stefan?
Oh, here's a good one. I've had 7 surgeries due to I assume, total hip replacement gone wrong 15 years ago. 2 sacroiliac joint fusions. How am I, now I'm waiting to have my hip redone and pelvic surgery. Need help with pain. So this patient is awaiting to have surgery under the care of 2 prominent orthopedic surgeons. So this patient has had 15 years of pain, numerous surgeries.
So this is a difficult one, and one of the things that we do as pain specialists is work with your team. So I think the key is to not work side by side the orthopedic surgeons, but to work with the orthopedic surgeons. So if they think the surgery is absolutely needed for a structural problem, then we have to work around that to allow them to safely do the surgery. And of course, we're anaesthetists as well, so we like to get involved with people's care in the hospitals, depending on where it's done, and providing some pain management around the time of surgery or some options. And I think once the surgery's done, once you've rehabilitated, we'll see if and what pain is left over. but you've got a long history, so a lot of your pain is going to be neuropathic, definitely. I don't know how much, but a lot of it. And I suspect you would probably get to the more advanced pain treatments quickly. I know Stefan's had some experience with this as well. And neuromodulation, nerve stimulation, spinal cord stimulation can be considered in some instances, depending on the individual circumstances, of course.
Yeah, I've looked after a patient with a very similar history quite recently. And this patient was referred by a hip surgeon who we collaborate with. And he, I think, was the third surgeon involved in this patient's care. And this involved, you know, a hip replacement, a few revisions, and then reconstructive surgery because there was a lot of tendon damage. So ultimately, this patient had a lot of nerve pain. And the mechanical issues were very well managed eventually by the referring surgeon, but then we just had to deal with the residual nerve pain. And this involved trialing a few simple options first, but eventually this patient did need spinal cord stimulation, which gave a very good result and essentially abolished all the nerve pain.
It works for nerve pain. It doesn't work for stiffness and weakness. That comes later with exercise and rehab. Somebody asked about a physiotherapist or a chiro. So we've got physios, we've got OTs. We're very much a hands-off practice generally, because we know that most physiotherapists don't understand, and I say this with care and respect, don't really understand chronic pain or the nature of chronic pain. And they'll just kind of lie you down and move you all over the place. And that generally can sometimes make pain worse. So physio is part of the team that helps people get back on track. Definitely. You've got to have somebody that understands pain, though.
There's been a couple of questions about whether or not you can see people from the country or interstate, and whether or not you do telehealth.
The short answer is yes. We've treated people as far away as South Africa and Hong Kong via telehealth, and we treat people from all states of Australia. So yes.
What is new in the treatment of severe migraine pain?
Migraine is the world's top #1 most debilitating pain condition, according to the WHO, or it's in the top 20. And it is incredibly debilitating. They're doing some studies with CGRP medications, which are injections. So they've had one on TGA that's had a couple of months of trialing, which got so-so results. They've got another one that's currently being looked at, so that everyone's looking for the magic bullet. But from our perspective, if it's proper chronic migraines, working with a neurologist to make sure all the neurological treatments and considerations have been done. There are some medications that can be tried for prevention. Usually they're quite high doses. I do suboccipital space pulse radiofrequency and sometimes pericranial Botox, not necessarily the Botox that neurologists give, but we give it in a slightly different way. And sometimes that can be enough just to reset things as well. I treated somebody with cluster headaches recently with some blocks to the nerves within the nose and the back of the head, and that was very good for treating the cluster headaches. We've had a lot of questions. Do we keep these questions, Lindy? Are we able to answer them offline?
Answer them offline. I think that there is a lot of questions here that are quite similar. Perhaps we could do just the top 10 questions or something that we could send off as a follow-up. I'd love to provide some information to everybody that joined tonight with some of the answers as well.
Good. Well, I've been very excited about doing this. I'm really excited that people were really proactive and came through with questions. This is the first time we've done this. I'm sure we'll be doing this again. We might aim to do it once every quarter or so. I'd be interested in maybe, I don't know if it was part of the poll questions, perhaps we could do something in terms of a Facebook group or something, really kind of help and support each other. But we're experimenting with a few ideas at the moment, but we will certainly be doing this again. And
Yes.
depending on who is interested, we might focus on back pain at some point, or neck pain and head pain. And so we can be a bit more specific about things.
We had 73% of the attendees tonight say that they would like to be on some sort of online community-based pain.
Okay.
So education, and 96% that they said they found this useful. Brilliant. And they'd like another one. They'd like to attend
Excellent.
another one. So that's
great
news.
Very good. And thanks. I've seen a few people that I know and have managed over the years. So I hope you're all doing well. I really wanted to thank the Ramsay team for helping us put this together. And if anyone's got any questions or worries, you know how to reach out to us, so please feel free to do so.
Lovely. Thank you. On behalf of Ramsay Healthcare and Pain Specialists Australia, we're going to let you go for tonight, but rest assured we will be in touch via some follow-up. All right. Take care. Everyone. Have a good night.
Bye-bye.
Thank you.